asistentes, ¿vale? Pues muchísima
Ok,
suerte a todos.
gracias.
Gracias.
Estamos aquí para lo que necesiten.
Gracias.
Gracias.
Bienvenidos a todos los presentes en esta sesión. Les recordamos que para poder obtener su constancia de asistencia, deberán colocar su nombre completo y correo electrónico en el chat de Zoom o en el chat de YouTube. Agradecemos de su atención.
Adelante, doctora Figueroa.
Gracias. Hola a todos, buenas noches. Eh, Bienvenidos a esta sesión extraordinaria del día 13 de mayo. Agradecemos al Colegio Mexicano por brindarnos este espacio. Bueno, cabe mencionar que esta sesión forma parte de nuestras actividades en GSK dentro del marco del Día Mundial del Lupus, una fecha cuyo objetivo es crear conciencia sobre la existencia de una enfermedad crónica y grave que en México afecta a 20 de cada 100,000 personas, con una alta prevalencia en mujeres entre los 20 y 40 años de edad que se encuentran en edad productiva y reproductiva. De aquí la importancia de su atención y diagnóstico temprano para brindarles una mejor calidad de vida. Sabemos que desde el momento en que se presentan los primeros síntomas de la enfermedad, el paciente inicia una gran batalla, tanto anímica, social, familiar, laboral, y bueno, esto debido a la heterogeneidad de las manifestaciones que suelen presentarse y el tiempo que transcurre entre la primera evaluación, el diagnóstico correcto y el inicio temprano del tratamiento, que permite el control de los síntomas y mejore la calidad de vida de nuestras pacientes. Cada una de las acciones que hacemos a diario impacta para que estas pacientes retomen su vida. Todos somos partes de esta lucha. En los últimos años, los avances de la ciencia han permitido que hoy existan opciones terapéuticas especialmente diseñadas para el beneficio de las pacientes que viven con lupus. Hoy, como equipo GSK, nuestro compromiso es lograr que estos pacientes puedan beneficiarse en forma oportuna de la terapia correcta, logrando para ellos una mejor oportunidad de control en la enfermedad, reducir la morbimortalidad asociada y mejorar la calidad de vida de cada una de ellas. En la sesión de hoy, titulada Nuevos Horizontes en la optimización del manejo del lupus eritematoso sistémico, tenemos el honor de tener como ponente a la doctora Marta Mosca. Ella es reumatóloga, es profesora de reumatología en la Universidad de Pisa y jefa de la Universidad de Reumatología en el Hacienda Hospedaliero Universitaria Piazzana de Italia. Coordina el programa de formación en reumatología y el European Reference Network. Ha colaborado con y en las recomendaciones del EULAR y ha publicado más de 200 artículos sobre lupus y enfermedades del tejido conectivo. Dirige actualmente la clínica de lupus y la clínica de embarazo desde el 2000. Es un honor contar con su presencia y su participación con nosotros en esta sesión. Le daré el control y la presentación para que ella pueda iniciar y al final tendremos un tiempo para preguntas sobre la sesión que brindará. Gracias por su presencia y adelante, doctora.
And thank you very much. I'm sorry I don't speak Spanish. I perfectly understand, but I'm unable to give the presentation in Spanish, so I will do this in English. It is really a big pleasure for me to be here with you this evening for you and this early morning for me, actually here in Italy. And as anticipated, I will be discussing about the management of lupus. So I hope that you are able to see the screen and everything is fine, right?
Yes, it's okay, doctor.
Okay, perfect. So this you already presented, and this is the agenda for the presentation. So what I would like to discuss over the next hour are these 3 points, basically. So the concept of the treatment of lupus today, I will highlight the unmet needs for our patients, the targets, and the recommendations to guide us in the choice of the treatment for our patients. Then I would like to highlight the role of biologics in the therapeutic paradigm for lupus. And finally, a short discussion about the protection for our patients from infection. So the impact of infections in lupus and the importance of vaccination. So let's start. And I would like to start with this point and this study. This is a study published in 1963. Actually, the study was designed to show the impact of glucocorticoids in the treatment of lupus. Here you see the great effect that glucocorticoids had on patients' survival when they were introduced in the treatment of lupus. Why this slide? We all know that glucocorticoids work in lupus. Actually, the reason why I'm showing to you this slide is to highlight how lupus is a severe disease. Because here you can see that in this study, the primary outcome at 5 years, I mean the outcome for patients was survival. So now we discuss about achieving low disease activity and remission, but lupus is a severe disease. I think that we need to keep this in mind when we see a patient with lupus and when we treat a patient with lupus, that even though we treat lupus better today, still this is a disease very severe. And not so long ago, the problem for this patient was really survival at 5 years. And I think that the best way to start our discussion, our chat this evening, is to see a clinical case. As we are all doctors, and we all see the patient as the one that I'm showing to you. She's a 23-year-old lady when she comes to our clinic, and she comes because she has malar rash, arthritis, and pericarditis. Diagnosis of lupus was made at that time, and the treatment was started, as you can see, with steroids, hydroxychloroquine, and azathioprine. The story of the patient goes on over the years. You see 1992, 4, 7, and 2002. And what you realize is a typical lupus. After 2 years from onset, she develops kidney involvement. At that time, the mainstay of treatment for kidney involvement was cyclophosphamide, which she receives when she's 25 years old. After 2 years, she presents a flare of her kidney involvement, and we changed the treatment with mycophenolate. After another 3 years, she presents another flare, and she also increases the dose of mycophenolate, increases the dose of glucocorticoids, and we move on. And in 2002, she presents an articular and cutaneous flare, where then the kidney involvement was controlled, so she's treated with methotrexate. You can see that there is a change over time of the immune suppressive drugs, but always a treatment with glucocorticoids with at different doses. We move on with the story of this patient. She presents another flare in 2014, and we treat her with Benlysta. At that time, we had belimumab in Italy, so we were able to give her belimumab. At that time, she's 47 years old, so the great part of her life now was with lupus. And finally, the disease goes to a control, enters into remission. So in 2022, the patient is with no disease activity, but she has a mild renal insufficiency. She has Jacob's arthropathy, she has osteoporosis, cataracts, thin skin, she's fatigued, she has muscle weakness. And I have added the fact that she had no children, because this was a big issue for her. She really wanted to have a baby, but she was unable to have a baby because of disease activity, but also the treatments that we gave her, which were not compatible with pregnancy. In 2022, she's 55 years old. She's been having lupus for 32 years. She's on steroids and hydroxychloroquine. But the story, unfortunately, goes very badly, because in 2024, she actually dies of acute aortic dissection, which actually we attributed to the chronic damage, to the chronic kidney disease, and to the use of glucocorticoids. Only 57 years old after 34 years of disease. Why I'm starting with this patient? Because I really believe that all of us have seen such a patient, and we face these issues in treating our patients with lupus: the need to reduce disease activity to a target, the need to prevent flares, the need to avoid persistently active disease, because in this case we need to maintain our patient with glucocorticoids. We actually have to say that even though glucocorticoids work very well in controlling the disease, glucocorticoids are not disease modifiers in lupus. Patients with lupus accrue damage. Quality of life is poor. As you've seen, she's fatigued, she had no children, and obviously lupus has an impact on patient survival. So when we consider lupus, I think that these really are the things that we need to consider and think about while we start treating our patients. And these concepts are clearly summarized in this overarching principle of the treat to target recommendations, which were published years ago, but really represent for me a mainstay of my thinking when I treat a patient with lupus. And this is the concept that when we treat a patient with lupus, we aim at ensuring long-term survival, at ensuring good quality of life, and at preventing damage. So when we treat a patient with lupus, this is what we have to think. We have to put our minds in the future. And the way to do this is to control disease activity, to minimize comorbidities and drug toxicity. So it is not really when we see a patient with lupus that we have only to think about activity. Controlling activity is a way to achieve the real target, because the real target for me is damage prevention, and I will show you that damage is really the core of the story. In fact, if you see, damage has an impact on really the long-term outcome, as damage is associated with mortality, is associated with a poor and slowing and decreasing quality of life. It is associated with additional damage, so it's kind of a loop, and it is also associated with costs, as patients with damage cost more to the society. On the left part of the slide, you see that damage is caused by disease activity, by glucocorticoids, by flares, by persistently active disease. So that's why we need to think about these points. But the damage and the right side are really our aims in treating patients with lupus. So I will take some time to show you damage and the impact of damage on our patients. If we go into the literature, we see that patients with lupus accrue damage. It's kind of inevitable. It looks like it's something, it happens in spite of what we do. This is not a new paper. It's a paper published years ago where you see that patients with lupus over 15 years accrue damage. And if you go into the literature, you continue to see this data. These data were published years ago and were the first 5 years of follow-up of the patients included in the SLEEK Inception cohort. So patients followed since the beginning of the disease, and you see half of these patients after 5 years had damage. Other data show damage accrual, mostly in a linear way, and with two peak increase at 5 and at 15 years. Maybe and probably the first peak related with the use of glucocorticoids, but also with the effects of disease activity, and 15 years, the high doses of glucocorticoids we used to give to our patients. And this is a summary of many papers published on this topic, again, all showing the linear increase of damage in our patients with lupus. Is this an issue of the past years because we were, let's say, less good in treating patients with lupus? I would say no, because if you go in the literature and you look at recently published data, you see that the story is still the same. This is a paper published in 2020. These you see patients followed up to 25 years. So I would say the new millennium, and again, about half of these patients have damage. And damage accrues also in those patients who have not a very high disease activity, showing the impact of glucocorticoids and treatments and damage in the accrual of damage. If we wonder what type of damage is more common and was more common in our patients, then we clearly see that damage is in great part related with the use of glucocorticoids. You see, for example, the ocular damage, but also to incomplete control of disease activity. You see the renal damage, you see the neurological damage, you see the joint deformities. So it is indeed a mixture related with the fact that we still face flares when we control disease activity, persistently active disease, and we use a little bit, probably too much, glucocorticoids. In this nice review, published in 2023, the authors have compared damage accrual over the decades in two different cohorts, in Toronto and in Karolinska. What they conclude by this analysis is that there is indeed an improvement, in fact. So the percentage of patients with no damage is increasing. So we have to say that we have worked in a better way in treating our patients with lupus, but unfortunately, the percentage of patients with damage, it is still too high. And there is a damage that it is mostly unchanged. You see the figures for the cardiovascular disease, for the renal disease, for the skin disease, still remain unchanged. So we perform a little bit better, but we do not perform well because our patients accrue damage and we are not able to control some types of disease manifestations, as in these areas we still have damage. So I would like to summarize these key messages on damage accrual, because damage occurs in patients with lupus, occurs early, and we will see this point in a short moment, and it occurs in patients with low disease activity, with persistent disease activity. As I anticipated, why I think damage is central and we need to put our heads on damage, because damage is associated with increased mortality risk. And this is clear in the literature. This is a paper published, it's a paper of 2020, and you can see that survival and estimates in patients with damage compared with patients with no damage is clearly different. So it is related with mortality, and each 1 unit increase in the damage index appears associated with a 34% increased risk of death. So it's quite a lot. But as I anticipated, damage is also associated with a reduced quality of life. Well, the data on the association of damage and quality of life are quite different in the literature. So in some parts of quality of life indeed are not related with damage, but the physical component is usually correlated. And what it is important to note is what this paper has showed, that when we have an increase of damage, then we have a simultaneous decrease of quality of life. And then patients go down, and then they stay on this reduced quality of life. So it has, in any case, an impact on the well-being of our patients. Why I show you also the health costs? Because, for example, in my country, my payers, the chief of my hospital, they actually control the costs of what we do and how we treat our patients. And they actually follow the use of what they call high-cost treatments. Immediately, when you treat a patient, it may look that we spend some money to treat these patients, but we need to keep in mind that we are saving money for the future, because if patients accrue damage, and here you can see data on the cost of patients with more than 5 of damage, then we see that they cost even more than what they would have costed by treating them in a better way. You see that a patient with no damage has a cost of 2,000 Canadian dollars versus 23,000 of a patient with damage. So it has an impact also on our society. So as I anticipated, we don't want damage. And for me, really, I always keep in mind damage. But what is the cause of damage? As I anticipated, these are the causes of damage. Disease activity, being active disease at disease onset, being flares during the follow-up, being persistently active disease, and for sure, glucocorticoids. Here you see the impact of different types of organ involvement in damage accrual. In a British cohort, you see kidney disease, you see CNS disease, which we are not so good at treating, antiphospholipid antibodies, and steroids. And here you see some data clearly showing that disease activity, high disease activity, is related with damage accrual. And you can see this here in this graph, where it is very clear that a SLEDAI above 10 has a different impact with respect with a SLEDAI of 6 or 7, which, by the way, it is already a significant SLEDAI. It is usually, it has been the cutoff to put patients into clinical trials. Here you see that the correlation between the damage accrual is true at baseline. So when you see a patient with lupus with high disease activity, you need to think that you have to lower this disease activity, because this could lead to high damage, but also not being at target. So it is what I was telling you, not only having high disease activity at onset, but not being able to attain low disease activity, or having a patient with a reduced disease activity but still persistently active, and high disease activity status. So this is the issue, because we will give them more glucocorticoids and we actually expose the patient to damage related with uncontrolled disease. But the second important points are glucocorticoids, which we love and hate, as you see that here the difference is related with a dose of 7.5 milligrams of prednisone per day. So it is quite a low dose if you put it this way, and we will see that with the EULAR recommendations, this dose is not the right one to keep and to maintain a patient with lupus. Glucocorticoids are cause of damage at the beginning of the disease and during follow-up, and very low doses of glucocorticoids are related with damage accrual, you see. And we all know that a very low dose of glucocorticoids, for example, is related with the development of osteoporosis, but also cardiovascular risk or dermatological manifestations. Early high doses of steroids are associated with damage. Here you can see. So if you treat patients with lupus with too high doses of glucocorticoids since the beginning of the disease, you are at risk of accruing damage. And this is what, again, I was telling to you, is 7.5 milligrams at study entry. In early lupus, while we treat the disease, these are Italian data, we use glucocorticoids, and after 3 years, in early patients, so at the beginning of the disease, 30% of patients have damage because we've been using too many glucocorticoids. And here you can see that 1 milligram per day of prednisolone is associated with damage. So the lower the dose, the better it is, even of 1 milligram per day. So the steroid sparing is very important in our patients. Obviously, when you enter the loop and you have damage, damage leads to damage. So we need to be very cautious of this. So disease activity is a cause of damage, glucocorticoid therapy is a cause of damage, and damage leads to additional damage. So is there a window of opportunity? This is the point. And my answer is yes, there is a window of opportunity, because we don't want our patient to have damage, but we have seen that until now it is kind of something that will happen, and due to many reasons. So why I believe that there is a window of opportunity? Because we see in the literature that in patients with a new disease onset, those patients who were not able to achieve low disease activity within the first 6 months are those patients who accrue more damage after 18 months. So this looks like we need to work very well at the beginning of the disease for our patients. And here, again, the data from the early lupus cohort of the Italian Society of Rheumatology. Again, early lupus, early damage, 30% of patients have damage in the first 3 years. This is also very important in kidneys, because we know that when we have renal involvement, first time you have renal lupus nephritis, then you have a damage and you have a nephron loss. And if you keep the patient with a persistently active kidney disease, if patients flare, the nephron loss is higher, is huge. And it goes with the physiological nephron loss that we have with aging. And so we move towards chronic kidney disease. So this is very important to be kept in mind, because in lupus nephritis, it is very clear that it is a severe situation since the very beginning. So there is a window of opportunity. We need to reduce disease activity early in the disease course. We need to prevent flares, and we need to taper steroids as soon as possible. This is the story. These are the data supporting the EULAR recommendation, which now I'm going to discuss with you. How can we do this? Well, we need a paradigm change. We need to change our mindset when we treat patients with lupus, and the EULAR recommendation represent a guidance to do so. Well, I'm biased, of course, but I think that really this update of the 2023 recommendation has made a change. And it has made a change starting from the overarching principles. The actually overarching principles D and E, to my view, are really the way we are guided when we start the treatment of our patients with lupus. Let's see the overarching principle D. Overarching principle D is telling us what we should consider the ingredients of our choice. So the patient characteristics, obviously we need to have socioeconomic considerations and access to drugs, because it is true that all the treatments I'm going to discuss are not available everywhere, and we have to be very aware of this. And we will discuss this, if you like, a little bit. The type and severity of organ involvement, the treatment-related harms, comorbidities, the risk for progressive organ damage, and what the patient wants, actually, within what it is possible, obviously. So this is a step towards a personalized therapy in lupus. And we can discuss about biomarkers, but we are not there yet. And then the overarching principle E. Why I like it? Because I think that this is telling us that today in lupus, we can start with a treat-to-target approach. This overarching principle is telling us, do not wait. Just be sure that you start very rapidly a treatment aiming at remission or low disease activity. So this, I think, is the biggest paradigm change, that we should not rely too much on glucocorticoids, hydroxychloroquine, and even, I would say in a slightly provocative way, only traditional immune suppressive drugs. So this is what the EULAR recommendations look like. And for the treat to target, we need to set the targets. And it's not strange that the targets are those that I discussed already, disease activity and glucocorticoids, because it's true that we don't want damage, but not to achieve, to accrue damage, we need to achieve these targets. And as I anticipated, for EULAR recommendations based on the data in the literature, the, let's say, lowest acceptable dose for maintaining a patient with lupus is 5 milligrams per day, is no higher than that. The targets are the targets of lupus low disease activity, of remission, and for remission it is the Doris definition of remission, and the dose of prednisone. Just to remind you that Doris remission means no clinical activity. It allows the serology and it asks you, I mean, to be in remission, a patient has to be on a prednisone dose not higher than 5 milligrams per day. Immunosuppressive therapies are allowed, so it is not a remission with no treatment. It is a clinical SLEDAI score of 0 on treatment and prednisone no more than 5 milligrams per day. LLDAS allows a little disease activity, and it allows, in the original definition, a prednisone dose of 7.5 milligram day, even though today, with the new recommendation, you have to consider the so-called LLDAS 5, because 7.5, it is not okay in the maintenance of patients with lupus. Why these targets? Because it has been clearly shown that both LLDAS and remission are associated with good outcomes, so with less damage accrual, with better quality of life, and improved survival. You need to maintain a patient in LLDAS for a slightly longer period to actually achieve the long-term targets, remission obviously being a more strict definition. I mean, can be, it is sufficient over the follow-up of patients to be in remission for a shorter time, or, as you can see, at least 2 consecutive years of remission, protective against damage. But these are the targets. How do we achieve the targets? Well, I could talk for 1 hour around this table, because this is really the heart of recommendations, in which you see, and I would like to focus your attention on the mild disease. You see that it is clear for a moderate disease, for a severe disease, we all start an immune suppressive drug. But what it is very interesting is really the prompt initiation of the immune suppressive therapy, even in mild cases where you have failed the first line treatment. So the story here is really to think in a treat-to-target approach. I treated my patient, the treatment is not working how I would like. I need to change the approach. How? Either by introducing an immune suppressive drug or by changing the immune suppressive drug or by adding a biologic. And here you see the armamentarium. We all know, we all use the traditional immune suppressive drugs, and we also have 2 biological drugs, which are in green because of obvious reason, because of the randomized controlled trials. Let's go to the glucocorticoid therapy. It is very clear with the EULAR recommendation that we have to use the doses of glucocorticoids needed for the type F severity of organ involvement. We could use pulses of glucocorticoids to try to lower the cumulative dose for our patient, but we need to maintain patients on no more than 5 milligrams, and if possible, glucocorticoid should be withdrawn, if possible. But I would like to tell you, at least reduce of 1 milligram, because we've seen that the 1 milligram less is less damage. So maybe we could start thinking about glucocorticoid as a bridging therapy. I use glucocorticoid when the disease is active, and then I taper and stop very rapidly. Well, we are not there yet in a complete way, but I think that this could become a way of thinking and a way of treating patients with lupus in the future. But this is the point. In patients not responding to hydroxychloroquine alone or with glucocorticoids, or patients unable to reduce glucocorticoids, so these patients might be already on an immune suppressive drug, then add immune suppressive drug, then I would say change immune suppressive drug and or a biologic agent. And if you recall the slide I showed you before, the prior use of traditional immune suppressive drugs should not be mandatory for initiating belimumab or anifrolumab. So when we drafted these recommendations, we thought that traditional immune suppressive drugs and biologics were on the same shelf. We could pick one or the other. Where are we with our standard of care? I'm perfectly aware of the fact that I'm a lucky person. I live in a country where I had Benlysta when it was available, and I had anifrolumab even before it was available on the market. And I hope I will have other treatments that are now going to the market. I had voclosporin, and I will have obinutuzumab. So I'm a very lucky person. And I'm perfectly aware that I'm lucky and that these treatments are not available everywhere. So I would like you to focus your attention on the fact that a treat-to-target approach means mindset, a way of treating patients with what we have. But then I would like to show you that if we have a biological treatment, we may do better. So, do we attain the targets in our cohorts, in our patients? Where are we? These are the data on the attainment of targets of the recommendations in patients with no disease activity entry criteria. So I look in my cohort and I see how many patients are in remission. And here I will go very rapidly around different cohorts. The Asia-Pacific cohort. At any time, 80% of patients are in LLDAS and more or less 35% of patients in remission. So high percentages. My cohort in PISA, very good percentages if you want, because we have, again, 60-70% of patients in LLDAS and around 30% of patients in remission. Then you see the Gladel cohort. Well, this shows a little different picture, as less patients really achieve these targets, while there is a higher percentages of patients not optimally controlled. So different figures, but then we can attain our targets in a way or the other. What about patients with active disease? Because it's not just attaining a target, it's I have a flare and I want to reach the target with the treatment I have available. So this is a very nice study from a Greek and Italian group. They retrospectively examined their patients with an active disease to see how many were reaching the targets. And they have observed that the targets were actually reached in a high percentage of patients. These were actually old patients, so a small percentages of these were treated with biologics. You see, 80% of patients have low disease activity for 6 months, but then for 24 months, just half of these patients. And remission is 27% of patients. The time to achieve the targets may be long, and these are data showed in other literature. This is a Chinese study showing that it might take up to 5 years to reach the targets. But I showed you that we don't have this time. We want to reach the targets early. And this is a time to response to immune suppressive therapy in my cohort with traditional immune suppressive drugs. You see at 3 months, it's 37% of patients. In LLDAS, 28% in remission. The best that we can do is 37% in remission at 1 year and 59% at 12 months. What does it mean? It means that I face in patients with a flare a persistently active disease in 40% of my patients, and this means that these patients will probably inevitably accrue damage. So we can achieve the targets. We have to say that, we perform well. These were not patients treated with a treat-to-target approach as the EULAR recommendations recommend, but achieving targets may take time, and we don't have much time, and achieving targets may be difficult. And it may be difficult because in some clinical manifestations, skin rashes, arthritis, high disease activity, high SLEDAI, it is more difficult to achieve LLDAS, and it is more difficult to achieve remission. And these are data from the literature supporting this fact. And this, again, is the Italian and Greek study, again showing that it is a cluster. There is a cluster of patients with predominant mucocutaneous and joint disease. They do not achieve remission. So it is really bad. So there are some flares which are difficult to treat. In our experience, still are those patients with skin and some joint manifestation. And here you again can see the predictors of remission and low disease activity in a multinational Latin American cohort. And let's say that not having skin, not having kidney, having a low disease activity is better. So obviously these are the, let's say, the easy patients if there is an easy lupus to treat. And I believe there is no easy lupus to treat. And finally, what is it? It's the other problem is preventing flares. Because if you again go into the literature, sustained low disease activity, it is not common. Sustained remission is even less common. So our patients lose the state and they flare. And more or less, if you enter and if you read the literature, you see that 25 patients who had the target flare over 1-2 years, more patients flare over the follow-up, over 10 years. So this is an issue, okay? So we can do things. We need to change the mindset. With traditional treatment, we can achieve our targets, but we are not perfect. And if we go to the steroid withdrawal, the picture is more or less similar. And we all know the French study in which patients were not treated with biologic. 30% of patients who stopped glucocorticoids flare. And this is also the experience of our group, where we retrospectively assessed patients who stopped glucocorticoids, and we had 30% major flares out of those patients who stopped glucocorticoids. So we can do this, but basically we have to face the fact that patients flare when we taper glucocorticoids or we stop glucocorticoids. This will always happen, but we would like to have less patients flaring when we stop glucocorticoids. So I can move on very fast because I realize that I'm speaking too much, and I would like to show you the data, real-world data. This is the SPOC population. It's a population followed for time for disease activity, glucocorticoids, and treatment. And you see 60% of patients receive glucocorticoids, 20% of patients more than 7.5 milligram day. And in the year before enrollment in the cohort, you see lots of patients had flares. So this is the picture. As this picture improved over the years, yes. Is this optimal? I would say no. So we have a good standard of care. We should work better, following EULAR recommendations, or maybe adding a new treatment. to the treatment of our patients. And this is what EULAR recommendations tell us. How can we use biologics then? Well, and what do biologics add to the standard of care? I would like to very briefly recap the data that we have on the use of the two biologics that we are largely using in patients with no renal involvement. And so here are the data on belimumab, showing the improvement of disease activity over trials, across clinical trials in lupus. You see the comparison of belimumab with placebo, and you see the reduction of disease activity. The Pluto trial is the trial on children. The ability to control disease activity, see the numbers and the percentages, but these are active patients, again, over at week 15, remission attainment and LLDAS attainment. And here you see the reduction of flares, which is the other issue. So we need to see, and we see very clearly the ability of belimumab to reduce the occurrence of flares compared with standard of care. Then we move on and we see that with the use of belimumab, it is possible over time to reduce glucocorticoids. So it is a support for the targets that we want to achieve. And obviously, this leads to less damage accrual. This is an interesting study comparing damage accrual with the Toronto cohort, and we see that there is a clear difference. So having reached the targets leads to the final target that is less damage. Obviously, this is related with an improvement of quality of life and fatigue in our patients. The real-world use of belimumab is rich because we've been using belimumab for a while now. Italy has made a story a little bit of this with a very nice study that it is the Berlin study, a multi-center Italian study enrolling patients treated with Benlysta. And in real life, the data are even better because we see better figures of achievement of LLDAS and remission. Here you can see the lupus low disease activity, high percentage of patient, the remission, high percentage of patient, even the SRI is very good. You can see that there is a good time to response, so low disease activity is achieved at 6 months in patients as compared, and even a good percentage of patients achieve remission at 6 months. The reduction of flares, there is a comparison with the flaring pattern before belimumab and the flaring pattern during belimumab in the same patients. And the reduction sustained of disease activity in patients. And these are the real life pictures. Anifrolumab has less real world data, but I'm showing to you the data of the TULIP trials and the long-term extension. Again, the reduction of disease activity, the achievement of the targets of remission and LDA. At the end, you see after the long-term extension, that's the difference with the Benlysta data at the beginning. And again, you can see the remission attainment after 4 years. Again, ability to prevent flares with respect to standard of care, and the reduction of glucocorticoids, both in the TULIP trials and the long-term extension with the treatment with anifrolumab. And the prevention of damage, the comparison cohort is the same. So it's still, and again, with the Toronto cohort. So you can see the data are pretty much comparable in this way. The damage accrual is again very good. So biologic can support us in reaching the target, and this is the health-related quality of life. So we are very happy about this because we know that biologics, and this is why they are there in the recommendations, support us in performing better because they are compared with the standard of care. In my experience, I can tell you, and this is the other part of the table that I showed you previously, that in fact what we see is that the time, the percentage of patients achieving targets when treated with biologics on standard of care is higher. Basically, all these patients, the majority of these patients in this study were treated with belimumab. And you see, at 3 months, more patients reach the target of LL-DAS, and at 3 months, again, more patients reach the target of remission, and even more at 6 months. And you know, this is a more restrictive target, so 47% are in remission at 6 months. So it is a very good picture. So if this is true, why should we use late in the follow-up of our patients' biologics? Because if we have a biologic and if we have a patient with an uncontrolled disease activity, and I think this is what basically EULAR recommendations and clinical experience tell us, I think that we should consider the fact that we could use these treatments early. So my point is that today we can, for many reasons, decide that the first immune suppressive drug should be a traditional one. But if this fails, we need to consider that the data support probably the addition of a biologic to the traditional immune suppressive drug. I will be provocative because I will show you also some data on the very use of biologic in naive patients as well. But if not in naive patients, for sure, I think that we should not wait and use all the traditional immune suppressive drugs before adding a biologic, because the data show us that adding a biologic gives an advantage. So if you don't reach the target, I think you should consider this option. And it is very important because this is the change in mindset. And that's why I'm going back to this patient. What if I had a biologic earlier? Probably I would have added this, and maybe, I'm saying maybe because I mean, we can never say, maybe I would have prevented some flares for this patient and this terrible outcome, because this was the way she was treated, the way we used to treat. This is the old paradigm treatment. We use glucocorticoids, we use high doses of glucocorticoids, we move with the trial and error approach from one treatment to the other until the end. But it is not true that one size fits all, because with this paradigm, my patients ended badly. Even though I think she was treated well, actually, she was treated, I mean, in a referral center, we try to use less glucocorticoids as possible. So how should we treat her today? Well, today, we should consider to add a biologic to her when is needed, when we are not able to control disease activity, when we are not able to prevent the flare. So first of all, the mindset is use immune suppressive drugs as soon as needed. And this was actually done in my patient. But then if this is not enough, do not move from one to the other. Try to add on something. And this could be a biological therapy. So what about biologics? The early use. Early means add early, add to the first failure of an immune suppressive drug, which is in the majority of cases my approach. I start in the majority of my patients with a traditional immune suppressive drug, but if I'm not happy now, today, I add a biologic. I do not move to another traditional immune suppressive drug. Or sometimes, may I use the treatment as monotherapy on hydroxychloroquine as first choice. So I don't have a clear answer to all these questions, but if we go into the literature, we can see that. First of all, and these are descriptive data, is a review made by an Italian group comparing the add-on treatment to hydroxychloroquine. If we use biologics, adding on to hydroxychloroquine and glucocorticoids compared with adding a traditional immune suppressive drug, we see that there is a difference. So I have a patient flaring, I need to put an immune suppressive drug. Should I put a traditional one or a biologic? That's your choice, that's the availability. But if we go and we just look at the literature, we can see some data, for example here, showing that it might be that you have a better response with belimumab and also with anifrolumab. You see on the left, belimumab and anifrolumab compared with an add-on of a traditional trial and error approach immune suppressive drug. It might be. We do not have such a study, but we also have data from my cohort. These are not comparing traditional and immune suppressive drugs, but are showing to you that in group 1, we used Benlysta in naive patients, added on hydroxychloroquine and glucocorticoids. In group 2, in a, let's say, more traditional way, added on traditional immune suppressive drug, and you see it is the majority. What I want to tell you is that basically the results are the same, but in those patients treated only with Benlysta, we use less glucocorticoids. So this is the important point. You can do this. You can do this in data show you that you have good results, and you may also end up using less glucocorticoids. From the Benlysta data, the early use of belimumab in those patients with no damage and shorter disease duration leads to better results. And the early use of belimumab is associated with a higher drug retention rate. So this means that our patients not only tolerate very well belimumab, but function very well. This is an approach to the early use, and this is an analysis of the data, of GSK data. Early use in this case was defined as less than 2 years of disease, no damage following the Benlysta data, and apparently no previous use of immune suppressive drugs as far as it was possible to understand. And what you see is that in those patients who have used the Benlysta early, so even on top of traditional immune suppressive drugs or not, they perform very well. They prevent well flares. They use less glucocorticoids. They accrue less damage. So I think that even though these are not direct data, it is convincing to think that we should use these drugs earlier, adding to the first failure of an immune suppressive drug, maybe also as monotherapy. And in some cases, based on the patient's characteristics, you may also need to use them upfront. Beerly is the study that will give us additional information, and we are all looking forward to the results of this study. I like to be very clear on the fact that there are less data on anifrolumab, but data on the use of anifrolumab as monotherapy are now going out in the literature, and there are also very good data showing that also anifrolumab as monotherapy in patients who have been upfront treated with anifrolumab are very good. So, and the data will come out. What about lupus nephritis? Severe disease. I think that there is no story in lupus nephritis, and it is very clear. It was not so clear in EULAR recommendations where we said consider the use of belimumab with mycophenolate and cyclophosphamide or voclosporin with mycophenolate. But in the KDIGO as well, it was like the EULAR, but in the new ACR recommendation recently published, is clear that when available, we should use a triple immune suppressive therapy because this leads to better results and to better control of kidney involvement in our patients, which is by definition a severe organ involvement. So let's see some patients because it's very late. I've been speaking a lot and I think that we should put this into practice. And this is a patient followed at a unit. She actually has a very early disease onset. She moved on with her disease. She had, when she was very young, glomerulonephritis, very well treated, traditional therapy. Patients respond to mycophenolate and hydroxychloroquine and glucocorticoids. This was her story. So it is a story of success with traditional treatment. So successful that when she grew up, she wanted to have a baby and she had a healthy baby boy and a very nice pregnancy. But after pregnancy, shortly after pregnancy, she presented with a disease flare, no renal flare. It was a cutaneous and joint flare. So we increased their glucocorticoids, but with the decrease of glucocorticoids, the disease came back. Again, we had Benlysta available at that time, so we were able to offer her belimumab. Please consider the fact that she had been having lupus for a while, and she had already taken a very high dose of glucocorticoids over time. So the choice of adding to azathioprine belimumab was an early choice in this flare for patients. So it was early in a flare with a very good result. The patient point of view, happy, because she wasn't feeling the burden of the disease. The physician point of view, good, because the patient was better. C, she's 18 years old. And she was in high school when I saw her for the very first time. So she develops fever, she complains of fatigue and hence arthralgia. She comes to the clinic and a diagnosis of lupus is made. Joints, skin, serology, and autoantibodies. She's treated with pulses of steroids and then rapidly tapered and hydroxychloroquine. But unfortunately, again, while tapering glucocorticoids, she doesn't want to be on glucocorticoids, she flares. So at that time, I discussed with her about the need of an immune suppressive drug. She was very unhappy. 18 years old, skin and joints. She didn't want to start methotrexate, which was my choice because she was worried of hair loss, of nausea. She had to go in her final exams in school. She was very worried about her appearance. And my point was that she needed an immune suppressive therapy. And that's when I decided to give her IV Benlysta on top of hydroxychloroquine. And I was able to control her disease activity, to taper glucocorticoids, and she actually was still unhappy about glucocorticoids at that time because she wanted to be on zero. I can tell you that now she's on zero glucocorticoids. But now I will move on to my last clinical case. This is, for me, a difficult to treat patient. I will make the story very short because we only have another 10 minutes, and I want to cover the point of vaccination in our patients. She's a very difficult patient. Again, a young patient with arthritis, malar rash, and alopecia, and serology. As you can see, she was treated in a very classical way. I would say she wasn't at the beginning treated at our unit. My concept is that for her type of lupus, she received a very high dose of glucocorticoids. I do not pulse patients with 1 gram for 3 days, never, unless they have a very life-threatening disease. But we pulse patients usually even for kidney with no more than 250 milligrams for 3 days. But the story is this one. She's treated and she responds to treatment, even though she's not in remission, you see, because in April, she's on 12.5 milligrams of prednisone and 20 milligrams of methotrexate, very brave patients, because she is a young woman and she's on this treatment. In fact, she's fine, but when she comes to see us, she is complaining about the side effects of the treatments because she has increased her weight. She suffers of side effects from methotrexate, 20 milligrams per day. When I saw her first time, she was fine, no clinical manifestation, so I tapered prednisone and I tapered methotrexate. And I was lucky enough to be successful. So we arrived to December 2017. We taper everything, but then in December 2017, she flares. So she increases again glucocorticoids. And the story starts now in a very typical way, I would say, because it's high doses of glucocorticoids, and then we taper steroids. What do we do? What do we do with methotrexate? I do not tolerate methotrexate. So when she flares, we add Benlysta and we stop methotrexate because she doesn't tolerate methotrexate at all. We are able to taper prednisone, to taper glucocorticoids, and to continue with Benlysta. She's fine for a while, but then she flares again. This may happen, so we stop Benlysta. And we start again with steroids, azathioprine, mycophenolate. It's a long story, but I'm not interested really in showing this to you. Patients, they may respond to a treatment, they may flare, they may not be adherent to treatment, and it's a lot of stories. What I want to show is on the right of this slide. She has received a huge dose of glucocorticoids and she develops herpes zoster. This is indeed her picture. So we fought against, we have an infection in a patient with a persistently active disease. So we have a problem here because we have infections in our patients, and infections in lupus have an increased rate. Over time and over the years, we observe that there is an increased rate of hospitalizations of patients with lupus due to infections, probably because we use, lots of immune suppressive drugs following our recommendation, which is needed, by the way, but this is what we have to pay, and we don't want to. The most common infection in hospitalized patients with lupus are pneumonia, sepsis, urinary tract infections, skin and soft tissues infections, and opportunistic infections. What the literature is telling us is that there is an increase of sepsis. There is pneumonia, which in very high percentage of patients is a bacterial infection. And our patients have 13 times increased risk of invasive pneumococcal infection. Sepsis is strictly associated with mortality, and we discussed that this is our final, our target is increased survival for our patients. We also have viral infections. Most common agents are cytomegalovirus, parvovirus, and herpes zoster. And we have to be aware that viral infection may mimic SLE sometimes, so it is very important to test patients for viral infection before we decide that what we see is disease activity. HPV is an issue, is correlated with the development of cancer and is associated with immune suppressive therapy. And the risk factors for infection are, of course, our treatment. In my patient, glucocorticoids. I have no doubt it was the abuse of glucocorticoids in these patients, but also high disease activity is associated with an increased risk of severe infection. We don't know, we have contrasting data about leukopenia and hypogammaglobulinemia, and someone claims that hydroxychloroquine is the magic treatment also protecting from infections. I laugh because we are all believers and we all give hydroxychloroquine to our patients. Glucocorticoids are bad at any dose. Okay, so there is no safe dose with glucocorticoids when it comes to infections. Obviously, the more it is, the worse it is. But the point is that infections might be related with disease flares. The literature is suggesting this. There are a few studies showing that patients with sepsis, they are at risk of severe flares, or might be related somehow because they are being treated because they are active, and so the disease is not controlled, or there is an infection which is a trigger for flares. This was an abstract presented at EULAR in Milano a few years ago, again showing that there is a risk of major flare following a major infection in lupus. So all this leads to the fact that we need to prevent infections. Again, this is the association of mortality with infections, very old data, 1976, confirmed in 2014. So it has not changed. Infections lead to death. And again, you see, infections lead to death. So poor control of disease activity, flares of disease, damage accrual, hospitalization, burden on patients, and increased mortality. So everything is playing against us, okay? Is against us considering our target. So we need to vaccinate our patients with lupus, and we don't do that. We don't do that because we have fear of flares, fear of side effects, and we have doubts that vaccination is effective in patients who are heavily immunosuppressed. Is this true? Well, I would say that the American recommendations and the EULAR recommendation tell us that we are not right, because many vaccinations in lupus are safe. They are not associated with an increased risk of side effects with respect to the general populations. They are not associated with an increased risk of flares of the disease, and the vaccinations are associated with an acceptable response and with protection from infections. So we need to vaccinate our patients. And in fact, in our recommendations, we recommend vaccination for herpes zoster virus, for HPV, for influenza, COVID-19, and pneumococcus. I have a few slides. I will go very rapidly. I made these slides just to tell you that this is based on data, not my opinion or only the opinion of those who participated to the development of recommendation. On influenza vaccination, we have data, and we know that it is okay. And the recommendation is to administer in line with the schedule of the general population. Pneumococcal vaccination, safe and well tolerated, and we need to administer the vaccine and then the booster, and then to boost every 5 years. The varicella zoster vaccine, there are less data. It is the recombinant vaccine because we have issues with attenuated live vaccines in our patients, immune suppressed. The data are not so many, but are increasing, are very reassuring, and we don't want to see the patient as the one we saw. I tell you that I vaccinated this patient, obviously, and because it is an issue. It is an issue related with glucocorticoids. It is strongly recommended. HPV vaccination, it is recommended for those patients who are not being vaccinated. young patients with lupus. Now the general population is usually already vaccinated before disease onset, so it might be mostly an issue for pediatric onset disease. SARS-CoV is safe. We know a lot now about SARS-CoV. We were very afraid, but now probably is the vaccine better studied in the history. And what can we do with treatments? If the patient is on glucocorticoid, high doses, should I vaccinate? Well, if it is on doses higher than 20 milligrams per day, surely administer flu. Defer other vaccines until the dose is reduced. Methotrexate is the only treatment for which we should consider what to do. But lupus is not rheumatoid arthritis. So you need to balance the risk of flaring with the advantage of withdrawing or stopping immunosuppressive drugs. For lupus, indeed, it is advised that you continue treatment. What we have, some data on belimumab, and belimumab does not appear to reduce the response to vaccines. So the idea is that you can continue treatment when you administer the pneumococcus vaccination, as in the general population, and the influenza vaccination. With rituximab, we know that this is not the case. So if you give rituximab, you need to schedule vaccination very carefully, because otherwise, and it is obvious, your patients are not going to respond. This you can read in the literature, is a recommendation for a vaccination in patients on biological agents. And I think that there are a few things that we need to consider. Consider the fact that holding medication may be at risk because patients could flare. And I mean, we may use methotrexate in patients with lupus, but the response is good. So my practice is not to withhold treatment in patients with lupus. I don't feel safe to do this for a vaccination. Live vaccination, on the contrary, require that we hold treatment. It is very clear. And in recommendations, we have very clear indications on this. And in conclusion, we need to vaccinate our patients. And my suggestion is to think about it when you diagnose lupus, because it is very rare that then we don't treat patients with lupus with an immunosuppressive drug. So do I give a vaccine if the disease is active? Yes, conditionally recommended. There is the two recommendations are not aligned. We do vaccinate patients with active disease, particularly if we think that we will start then a B depleting therapy. So in case, the worst scenario could be that it is not working very well, but the best scenario is that we are protecting our patients somehow. So I'm going to the end of this long story and on the treatment of lupus, just with a thought. What is a paradigm shift? It's very interesting. I bumped into this into a review reporting about this paper, 1962, where a definition of the paradigm shift is given. So we have usually long period where we behave in a specific way, and then we have brief moments in which we change an idea. And we are living in a moment in which the concept has changed, I believe, because we have lots of knowledge and lots of new opportunities. But then we have to adopt the paradigm shift. So we talk a lot about the paradigm shift. We see the paradigm shift, but I feel that we are living in the pre-paradigm shift. So we are changing now. We are making the paradigm shift. It takes time. It takes data. We are developing new data. We are searching for the data available in the literature. I think that we are already in the position in which we are making changes. As I've showed you in PISA, we are making changes. We are using biologics and immunosuppressive drugs in a different way. We need, obviously, new data. We need to convince ourselves. We need to make our experience, but we are there. We need to change this because the data support the fact that the patients with lupus deserve to be treated in a different way. So we need to consider early introduction of immunosuppressive drugs. And I think that we are moving away from the trial and error approach on the treatment of lupus, and we are entering the way of the treat to target, the new opportunities, the no damage, and I dare to say an important window of opportunity for treating our patients. This is very important for the newly diagnosed patient with lupus, but it has an impact also on the other patients when they flare. So it is early in the disease, but it is also early in a flare, even in a patient with a long-standing disease as the one I showed you, 10 years, new flare, early use of a biologic drug. So I hope that you are still there with me and I mean, for you is late night. Now for me is almost morning, is almost time to go to the clinic. But it was really a pleasure to share this story with you. And then thank you very much for your attention.
Thanks,
So
Dr. Marta. Yeah. We don't see any questions in chat here in Zoom or in YouTube, but maybe we can end the session. Thank you so much for this rich presentation. We need to change for the patients, for the quality of life of patients, but we need time because we don't have all of these options available in Mexico, but we need to change for patients. Thank you so much for this presentation and have a great day.
thank you very much for having me with you. And I just would like to add that I totally agree. I think that is not just a story of options, but it's a story of mindset. That's the reason why I really wanted to show you that, first of all, we change our approach and our ideas. We use what we have, and then we are ready when we will have new approaches and availability of different treatments to use them as well. So I think it is very important to put our heads in this perspective. So thank you very much for this opportunity.
Thank you so much. Gracias a todos por su participación y por mantenerse conectados en esta sesión. Les agradecemos mucho su tiempo. Buenas noches a todos. Gracias, doctora.
Thank you.
Hasta luego.
Bye bye.
Bye.